Good morning, everyone, and good evening to those who are in a different time zone. And thank you all for today's edition of Patcast. Today is July 22nd, 2025. It's a Tuesday. I am Rifat Manan in California. And we are very delighted to welcome back Dr. Deepti Dhall, who had presented on our platform earlier. And Dr. Dhall is a renowned GI pathologist, and currently she works at Baylor Scott and White Health in Texas as a staff pathologist. And she is also adjunct professor at University of Alabama at Birmingham. And we are delighted to have Dr. Dhall with us today. She is going to deal with a very practical topic and day-to-day topic in GI pathology that we deal with every day. And she's going to talk today on colon cancer diagnosis, how pathologists face day-to-day problems in practical aspects. So we are happy to have her with us. And we also have some residents from Baylor Scott and White Health who joined us. Thank you for joining us also. And over to you now, Dr. Dhall. Thank you again.
Hello, everybody. Thanks for joining in. And thank you to Rifat. He's a very good friend of mine. He asked me to do this. I know the topic is like extensive, but I'm going to just cover the issues, what we face every day. I don't consider myself as a big expert in colorectal cancers, but I have signed out a lot of colon cancers in my 20-year career. So I'm going to start here and let me stop my video for a second. Give me a second. All right. So these are the things I was thinking to cover today. We all know how colon cancer looks like, but sometimes when we get the biopsies and resection specimen, it does not look like a typical colon cancer. And then we start worrying what it could be. Is it metastasis? Is it not colon cancer? And sometimes I think we do confuse the clinicians. If there's a large colonic mass, it is most likely a colonic primary if it's a mucosal base obstructing mass. And I've seen my colleagues doing, lots of stains to figure this out, but I'll show you some patterns. In fact, any pattern can be seen in colon cancer. And I think a diagnosis of colon cancer and biopsy really depends on the endoscopic findings of a colon mass. We'll cover some staging issues and some reporting issues. We all do synoptic reporting on colon cancers. And also I will like to include some, I do a lot of biopsies these days. And sometimes when you have a busy practice and you're signing out like, colon mass and you just say polydiff adenocarcinoma or carcinoma, you just have to give it a little bit thought that could this be something else? So I'll show you some patterns which should make you think, am I dealing with a metastatic tumor rather than a colonic primary? So this is a typical colon cancer case from yesterday. For beginners who are residents, there are columnar cells. They usually form glands. There you may see goblet cells here and there. You may see intracytoplasmic mucin, and very typically you see this luminal necrosis. So very typical colonic adenocarcinoma pattern. So case number 1. This is a rectal cancer resection specimen. You're looking at treatment effect. Why there's treatment effect? If you see in the background, there's a lot of fibrosis. And you see a typical colonic adenocarcinoma on the right, which is extending into the muscle. These areas look different, so we are going to go high power on these areas. And you start seeing the typical colonic adenocarcinoma here, and then you start seeing these tumor cells in nest. Some of them are larger nest, and every time when you look at a neuroendocrine tumor, it's always nested and the cells are uniform. So it makes me think, am I dealing with a neuroendocrine neoplasm here? And when there's a neuroendocrine neoplasm associated with adenocarcinoma, this could be a MNN, which is mixed neuroendocrine, non-neuroendocrine neoplasm. And it looks neuroendocrine. And we did the stains, and here in high power you can see very neuroendocrine like appearance, which is nested appearance, uniform cells, fairly abundant cytoplasm. And these are synaptophysin immunostain, and even chromogranin was positive. And you can see how there is like a bigger nest and all surrounding adenocarcinomas. And for a moment you think, am I dealing with a mixed neuroendocrine, non-neuroendocrine neoplasm? Um, in a setting of adenocarcinoma, the neuroendocrine neoplasm is usually neuroendocrine carcinoma. But if you go back, these look very well differentiated, right? There is no necrosis. There was not much mitotic activity. So is this a neuroendocrine tumor, or is this a neuroendocrine carcinoma which is showing treatment effect? And with treatment effect, the morphology changes. So and here you can see a lot of treatment effects, right? There is a lot of fibrosis around the adenocarcinoma, and this is again high power of those nests. I was getting confused when we had this case, is this menin or not? But if you know this process, it becomes very easy. Dr. Shia, she's at Memorial, she's my mentor, and she wrote this paper long time back that in treated rectal adenocarcinomas, you can see this endocrine cell differentiation. Now we call it neuroendocrine differentiation. And that is the change she described in particularly rectal tumors. And actually, if you note, I'm sure people who sign out GI, they have seen this commonly, that treated rectal tumors can show neuroendocrine differentiation. We have seen the features, what I just described, nested cells. Very typically, you see eosinophilic cytoplasm and round nuclei. And if you're getting confused, you can do Ki-67. Ki-67 is very low in these cases. So just remember that you can have these nests in treated rectal tumors. And typically, the tumor will show advanced treatment response, and it looks different, as I showed you. But they can look a little bit pleomorphic. They may have bigger nucleoli, so it might be confusing. I think the point, which is I bolded it, cytoplasmic eosinophilia and low Ki-67. And I think you may not describe that to confuse the clinicians. You can just write in the comment or in the microscopic, because this does not meet any specific neuroendocrine treatment. It's just a response. So remember this. And I got confused after doing many years of practice, and I thought this is a nice case to show. In contrast, you see these cells. This is the same thing. You're seeing nested cell. It looks atypical. There's a lot of apoptotic debris, and if you start looking, you see a lot of mitotic activity. And this is a recent case we had. This was an adenocarcinoma, associated villus adenoma, a very small component of this, which was a neuroendocrine carcinoma. And Ki-67 is very helpful. This is a deeper section. The tumor was dying away, but Ki-67 is almost 90%. These are common more in colonic tumors, untreated tumors. Of course, you can see this in treated carcinoma too, but morphology really matters. Case number 2. This is a biopsy from a liver metastasis, from a liver biopsy. And always when we are looking at a liver biopsy, history is very important. Really important. Histology is important. History is very important too. This is like a bizarre appearance, right? I would not think this is adenocarcinoma from colon, but when you look in the history, patient has a large right-sided colonic mass and multiple liver masses, and they're just trying to exclude, just trying to, make a diagnosis of metastatic colon cancer. So sometimes colon cancer can have a lot of clear cells, and colon carcinoma with clear cell features have been described. Sometimes these clear cells, they overlap with what we call as primitive appearance, or the yolk sac appearance, or the hepatoid appearance, because they can have a lot of overlapping patterns. Some cells may be eosinophilic. So for example, these are two different cases I got. Just to keep in mind that colon cell carcinoma can have clear cell cytoplasm. And this look more like nested. And if you look at a lot of HCCs, you kind of think, could this be a HCC, especially in a liver biopsy? So before making that diagnosis of HCC, and if it looks hepatoid to you, and if you're going to stain this, it's going to stain with HEPAR. So you have to make sure if the clinical history is that they are thinking of MET and there's a colon primary, that any adenocarcinoma from GI tract can have a hepatoid appearance. This is a very rare phenomena I am talking about. And not everywhere it looked hepatoid. This one looked kind of like a primitive gut appearance to me, like almost like a yolk sac type. And this is a resection specimen just to show you that if you have what is hepatoid or enteroblastic features, they're also called as colon carcinoma with enteroblastic features. This is a resection specimen, more very polydifferentiate carcinoma, and which were more clear, more enteroblastic. They were actually staining with glypigen and SAL4, which are markers for enteroblastic differentiation. This is a SADB2 immunostain, just showing how some area which is showing more enteroblastic differentiation is kind of weakly staining with SADB2. So these are tumors with these are described, they're rare. Just telling you because it's an odd morphology. It might look hepatoid, it might look primitive. Think of these markers, doing these markers. Any of these markers will be positive, especially a clear cytoplasm. And they are described to be, they're aggressive tumors, they have poor prognosis and things like that. It's not in a WHO subtype or anything, but just to remember that pattern can be seen in colonic adenocarcinoma. And if you see in resection, it's a poor prognostic tumor. So try to look for, make sure there are enough sections because they're often high staged and, often with aggressive tumors. Here is another tumor. Not very uncommon. You might see this in the biopsy, sheets of cells. The tricky part, the helpful part is there's a lot of lymphocytic cells. Sometimes you can get a lot of neutrophils. And the first thing, if you do GYN, it makes me think, could this be an undifferentiated carcinoma or just a polydifferentiated carcinoma? But we're not going to diagnose this in biopsy, but it is important to think of this tumor. And anyway, we always do mismatch repair immunostains in colon biopsies, and this will be most of the times MMR deficient tumor. This has medullary features, and there is in a resection specimen. Sadly, there's no cutoff, what percentage you need to call this medullary carcinoma. You can see this admixed with other components. But if you see predominantly this pattern, or at least, a significant portion, you can say medullary carcinoma or medullary carcinoma features rather than polydifferentiated carcinoma. And of course, the differential is neuroendocrine carcinoma, solid sheets of cells. There are uniform cells over here. So most of the times, this would be negative for neuroendocrine carcinoma markers. Focal positivity is not diagnostic for neuroendocrine carcinoma. So, all this pattern make a diagnosis of medullary carcinoma because this does not warrant a diagnosis of polydifferentiated carcinoma. Even it looks polydifferentiated, it would behave better. It's a better tumor. So this is a pattern, sheets, uniform cells. And also it shows pushing invasion, and they have abundant cytoplasm. Inflammatory infiltrate really helps me. And, just in a recent paper in 2021, they said only 1/3 are correctly diagnosed. So always make sure, you know this. It's there, it's very well known, but, it's just like when we are in a high practice, we might not think about this. And this is a meta-analysis paper. Again, I think the most important thing is, let's say if you have this in biopsy and you try to do stains, okay, let me prove it's colonic primary, and then it will not stain like a colonic tumor because it's often CK20 negative. It may express CK7, it is CK20, it is CDX2 negative. So, it does not stain like a colon cancer. So if you look at the colon, you look at the history, patient has a large colonic mass, you do MMR stains and it will show MLH1 deficient tumor. And then you can do SADB2. SADB2 is positive in these tumors. But remember is they do better than polydifferentiated carcinoma, even they look poorly differentiated. This is a similar pattern whenever you have sheets of tumor cells, and I've showed you one example. Always think, and especially it looks different than adenocarcinoma component. Please do neuroendocrine carcinoma markers, because sometimes like this picture on the right, it just looks like very undifferentiated, polydifferentiated adenocarcinoma. This stains strongly with synaptophysin and chromogranin. Now, what's the cutoff? In some papers, they say 20%. You have to see good positivity, 20%. You have to first appreciate the neuroendocrine morphology, which is nested sheets, uniform cells. And then if it's more than 20% positivity for neuroendocrine markers, then you can say neuroendocrine carcinoma. This is important because the therapy is different. Here, of course, this can be in a form of menin, right? You can have an adenocarcinoma, or it could be just arising in an adenoma. Sometimes colon cancers have pancreatobiliary features. Look at that. It does not look like colon cancer at all, and it will stain like pancreatobiliary. So the whole thing is that you can have a lot of different morphologies. The micropapillary carcinoma, this is a great example I had. It's a WHO subtype. It's an aggressive neoplasm. They've kept it as a subtype because it has different molecular features. They say there's a nuclear reverse polarity in this. So the luminal side will face outside, and that's why it forms this cleft around those nests. Make a note of this carcinoma subtype. Again, if you see this, try, look harder for LVI. It's often presents with high stage. So I think by itself, each subtype is to recognize the pattern in the biopsy, recognize that there are aggressive subtypes, and then look for those, look closer for more prognostic factors, which is LVI, lymph node, high stage, and all that stuff. I will move to challenges in staging now, which we all face every day. And PT4 is the most important thing for staging. Why? Because for stage 2 tumors, which is PT3 and 0, and PT4 and 0, these are N0 tumors, if we say PT4 in the staging, that would lead to adjuvant therapy. So currently, clinical guidelines will only look at PT4. So imagine how important it is. And we have to really make sure, first thing in the grossing, that if tumor is close to the serosa, one section is not enough. I would say at least take 3 sections of tumor abutting serosa, close to serosa, and focus the sections on that. Sometimes I see big sections, adenoma, adenocarcinoma. When you're focusing on T4, focus on tumor and the serosa. The grossing is absolutely important to make that diagnosis. And remember, even when the patient have positive lymph nodes, PT4 diagnosis is still very important because it changes the amount of chemotherapy. If it's PT3 and 1, patient will receive 3 months of chemotherapy. If it's T4, patient will receive 6 months of chemotherapy. So the most important thing for us in the colon cancer is to look at PT4. And of course, we follow CAP criteria, and I just noticed it recently got revised just last month. And they have not changed anything regarding how to identify T4 tumors. So either tumor has to be at the serosal surface, or it is continuous to the serosal surface through inflammation. They left this definition there. I think this definition is very confusing sometimes for people, but I think the examples they are giving is this, that let's say if the tumor is perforating, mostly there's gross perforation, then you may not see tumor on the seroral surface because it perforates, and all you will see is tumor abscess, like just acute inflammatory infiltrate and fibrin, and then serosa. So it's not, you don't see tumor cells on serosal surface, but you'll see this very dense inflammatory infiltrate. So that would be considered as T4A. But this definition is very confusing. And that's why if you don't see these things, the tumor at the serosus surface, deeper levels and extra sections are very, very helpful. Um, so the problem is about this, and you will see a lot of literature about this. Tumor less than 1 millimeter. Should we do it? How should we stage it? But if you follow CAP, if the tumor is less than 1 millimeter, and if after deeper sections and extra sections you don't see the criteria, then you can't call that T4. You can put a note there, they may have a higher risk, and that is it. So these are the examples I have. And Rifat is a GI pathologist. There must be some GI pathologist logged in. We can discuss this in the discussion section. I think this is T4. It's mucinous tumor. I know the tumor cells are right there, but you can do deeper sections, and I'm sure you'll find tumor cells and see the mucinous almost like the tumor is perforating through the serosa. And if you do deeper sections, you might find tumor cells or not. This one here, if you look here, tumor cells, it's the same case actually. If you see this, you'll say, oh, tumor cells are not on the serosus surface. But if I take you there, one of the deeper sections, see the tumor cells are going all the way here. Probably it's touching the mesothelial lining here. You can do mesothelial stains to see tumor cells on the mesothelial lining. This everybody would call T3, even though this is less than 1 millimeter, there is fibroinflammatory response. It may have a higher risk, but we can't call this T4 according to CAP criteria. These cases are more confusing. You can see very dense inflammatory infiltrate on the right side. On the left, you can see a little bit of fibrin and neutrophils. But these are very close. But I think keep doing deeper sections, you will see tumor cells extending to the mesothelial lining. If you don't, I show the cases at the consensus. I think in practice, people call them T4A, and you can do multiple deeper sections. This is, more examples of that. I'm thinking of T4A, just do more deeper, try to get to see tumor cells on the mesothelial lining. I think probably this is a mesothelial lining right there. And this is a mesothelial lining, and the tumor is almost touching there. This is the, Deepti, my friend, a very good friend of mine. She wrote this paper after doing this, survey that people, all the GI pathologists, even though the tumor is not at the serosus surface, they are calling it T4A. And she did a study, and she found there's all these tumor less than 1 millimeter. They fall in between the T3 tumors and T4. I would still, they are not at T4 here. And she separated this group 2, which is less than 1 millimeter. And look, group 2B, which is inflammatory response, only. Some of them are doing as bad as T4 tumors. So that's why if there's a lot of just inflammation, no connective tissue, it's probably T4. And this was a paper which came recently, Modern Pathology 2022. I do digital pathology these days, and it really helps me measuring all these things. That's the cool part of digital pathology. And they measured this distance, not 1 millimeter. They are saying 100 microns. So that is 0.1 millimeter. So if you see tumors with 0.1 millimeter, less than 0.1 millimeter, they do the same as T4A tumors. So if you see the blue line, which is the T4A tumors at the serosa, and if you see the red line, this is recurrence. They are looking at peritoneal recurrence. It is more peritoneal recurrence in cases which are less than 100 microns. So the CAP did not change anything in June edition, but I think in clinical practice, if they're really close, just try hard to find PT4. Consensus, and in fact, there is a lot of variability. I can just tell you what is out there and how I do it. Tumor deposits is another, change, lot of definitions. Current definition is that if you don't see residual lymphoid tissue in a nodule, in the advancing edge of the tumor. So if any nodule you see in the pericolonic fat in the advancing edge away from the tumor, and if you don't see lymphoid tissue around it, you can call it tumor deposit. It is not that uncommon. Of course, it is poorly reproducible. There's only agreement in 44% of cases in one study. But here is the in bold. If you this is the definition, AJCC definition, which is kind of confusing little bit. It says there should not be any evidence of vascular, perineural, or lymphatic invasion. The argument is that tumor deposits often have or may have vascular invasion in that focus, or there may be perineural invasion. I'll give you some examples. You could still call it tumor deposit if the tumor is outside and it's in the fat. That's how I do it. So this is the problem. These are the problems I just saying that the current staging. And I just heard from Dr. K. Washington. In fact, the AJCC investigators, they presented a platform in May in ASCO meeting that they are going to change the staging a little bit. I'm going to talk a little bit about it. In the sense that tumor deposits are very important, even in the presence of lymph node metastasis. So currently it is staged as N1C. And I'll discuss this with examples. So again, many tumor deposits will show LVI, will show perineural invasion, but that does not mean it's a tumor deposit. And tumor deposits here, they have an independent prognostic impact. So these are very important. So first is T4 staging, then is lymph node metastasis, and then is tumor deposits. So let's see, this is, if you look at NCCN guidelines, they describe in tumor deposit, they use the word irregular, even though irregular was an older criteria. I still take that into account. Lymph node metastases are not that often irregular, but of course, we have to follow the rules. It's kind of encapsulated, kind of focally irregular. There is focal lymphoid tissue over here, but I think most people will call this tumor deposit. Here, this is higher power. So this is a study I was talking about where this is written by last author, Dr. Nachtegaal from Netherlands. She has written a lot about this, and there are a lot of prominent people over here you can see. And what the conclusion is, even though we see LVI or perineural or lymphatic within these tumor deposits, it's okay to call them as tumor deposits. It doesn't have to be solely in the vessel. It doesn't have to be solely perineural invasion. But if it's a big tumor nodule or a tumor nodule in the fat with evidence of this, you can call this as the tumor deposits. And of course, I'll talk more about it. So this is a tumor deposit here. You can see an evidence of vascular invasion here. But see, the tumor is all outside in the fat, and this is perineural invasion too. So I would call this as a tumor deposit. Always make sure this is away from the tumor. So grossing really helps. When people find a nodule in very close to the tumor, I tell them take a section of the main mass with the nodule. I want to see the intervening tissue, because sometimes you can have discontinuous primary tumor, especially in rectal tumors when it's treated. So you have to prove that it's away from the main tumor. Again, it's not defined what is away, but fairly away. So these are few studies which are, upcoming after the AJCC staging, where when we see a tumor deposit and no lymph node, we call them N1C, and it's kind of ignored. The tumor deposit is ignored in general in the current AJCC staging system. This is one study, clinical trial, and if you can see, they proved it that tumor deposits are very important prognostically. And even the number of tumor deposits are important. And that's what is in the CAP staging system. And they combined the number of tumor deposits and the number of lymph node and came up with the final staging. And this is going to reflect in the upcoming staging whenever the staging is going to change. These are two more recent clinical papers in 2023. Can't see it's recently. These are also 2023, and you can see the number of patients. So it's not just a small study, it's all these clinical trial based, and all of them are saying tumor deposits are associated with more advanced disease, and we should, even if though they are lymph nodes, tumor deposits are important, independently important here. So another one, there are lots of studies. So now what's going to happen, uh, at least what was presented in ASCO, that we do the T4 staging, we do the N staging, and if we see a tumor deposit, there will be a, you can upstage the tumor. That's how they presented it. So if it is a stage 2A, and if you see a tumor deposit and no lymph nodes, you can call it 2B, something like that. So tumor deposits are important, even if there are positive lymph nodes, and number of tumor deposits are important. So it's very important to make that diagnosis. Next is tumor budding. I know we were all very scared to do this in the beginning when Dr. Nachtigall's, again, this came from Netherlands, when they did this study, we were very nervous because it's not reproducible, or how will we do this, and we are lazy to count, but it is in the CAP synoptic template, and it is very important prognostically. So these are single cells in the advancing edge of the tumor, or cells up to 4 cells. And why they are important? Because they represent what the phenomena is called epithelial mesenchymal transition, which is needed for metastasis. So these things are very important for malignant polyps, and I will show you a few cases. This is the recently, you should read this paper. It was a consensus paper published in Modern Pathology 2016. Consensus paper was, initially the paper was published in 2016, then another paper was published in 2021. This is from 2016 paper. Even in CAP guidelines, they tell you how to do it. When you are screening through the case, try to find an area where you see highest number of tumor budding. Then you go to 20x field and try to count them. Again, I'm doing digital pathology these days, so it's very easy. I make a circle of 0.73 millimeter square, and I count tumor budding. Very important not to count pseudo budding, which can be difficult. Immunostains are not, you can only do immunostains to visualize it, not for counting it, then you will overcount it. So let's see. Just to know the concept of polydifferentiate clusters, it's the same continuum to tumor budding, it's just 5 or more cells. Dr. Shivji wrote this paper that he said you can, if you take this also into account together, it is more prognostic. But it is, for now, it is not in the CAP criteria. And if you see this, you can report in your comment, and they're often associated with tumor buds, which I will show you. So here you can see, I see more tumor buds here, which are 5 or more cells. Maybe this is polydifferentiate clusters, because there are 5 or more cells, and there are single cells, which are tumor buds. Here I see more tumor buds. You can see single cells here. And sometimes I get confused, what are stromal cells, what are tumor buds. So sometimes keratin stain can help, but of course degree of nuclear atypia is helpful. And this is one of my recent case. If you're going too fast and there's a lot of inflammatory infiltrate and a lot of stromal reactive changes, you can really do keratin stain to highlight tumor buds and see where is the most tumor budding, and you count tumor bud in this area. This was a nice case of high-grade tumor budding I saw. I need to tell you that Dr. Nachtigall presented at USCAP this week, this year, and she was saying, be careful of these pseudobuds. Pseudobuds arise from fragmentation of glands. So when the gland is fragmented, you can see these single cells, and those are not tumor buds. So make sure you don't count in an area where the glands are fragmented. Another thing, she was seeing a very cool thing. She was saying on keratin stain, those pseudo buds will show some tadpole appearance. Like you can look at her presentation. It was, I don't do a lot of keratin, so not familiar with that. but we need to report this, especially in malignant polyps. It is very important because it's an independent prognostic factor for lymph node metastasis. And if we see this kind of high-grade tumor bedding, patient needs surgery because it has a high risk for lymph node metastasis, even though it's a well-differentiated tumor and no LVI. So this is very important. Large vessel invasion, we all know it's very important. People who do GI, we know how to identify these. It's a very you can see prominent artery and you see tumor next to it. Then you have where is the vein, and then you wonder, oh, that's a large vessel invasion. Also protruding tongue sign. And a lot of literature I've written, elastic stain is absolutely very important. In fact, I heard Dr. Pai saying once he does these stains routinely, if I'm remembering correctly. I have a very low threshold. It's a cheap stain. Anything where it's even slightly, I'm thinking this could be large vessel invasion, I would just do elastic stain when I'm just reviewing the case first. So here are some examples. If you are going too fast, it will just look like a T3 tumor over here. These are all large vessel invasion. This will also look like T3, but see artery running nearby. There's an artery here. There's no vein. There's an artery here, no vein. This was large vessel invasion. That was large vessel invasion. This was also large vessel invasion. Here there's an artery. So very often you will see an artery next to it. So you really have to do elastic stain in these. That's a high power. Sometimes you will see the smooth muscle around it, a smooth muscle there. But this is elastic stain. You have to, that's a protruding sign. Tumor going in the fat. That's an artery, and you can see broken elastic lamina here. So this is a venous invasion, extramural venous invasion. Another example over here, a very fibrotic tumor, it's not very clear. But see how the tongue is going into the fat, and then when I did elastic stain, probably on a deeper level, beautifully elastic stain is highlighting a venous wall over here with tumor in the space over there. So large vessel invasion is very important. I also do Desmond IHC sometimes because elastic lamina, sometimes elastic stain don't work. Sometimes it's difficult in some practice. It becomes too dark black, or so if you see like a smooth muscle surrounding it, it supports that there is a large vessel here. You can see smooth muscle bundle over here. I learned recently in one of the paper, you can also actually see smooth muscle around the lymph nodes. So it has to look like it shouldn't be a lymph node. So don't just go by the smooth muscle marker. EVG and Desmond together can be helpful. Of course, small vessel invasion is easy to is missed sometimes. You can have I take help of D240 often. I take help of D240 in malignant polyps too. For small vessel invasion, sometimes it looks like an artifactual space. I'm not sure. So I feel very good when I see tumor cells surrounded by D240. If you are good morphologically, you don't have to do it. Some people don't do it. Again, very important to diagnose this. There are papers there. People say that, why LVI is not clinically significant, because we miss all these LVI. If we start diagnosing them correctly, probably we can make a right diagnosis. So I'm going to quickly go over some colon biopsies. Colon biopsy looks like colonic adenocarcinoma, right? I'm changing gear here over here. It looks columnar, but you know what? The cells are not very pleomorphic. She's female. And you've got to look at the history. This patient has a history of endometrioid carcinoma. The only thing sometimes, even on frozen sections, you can get confused with colonic adenocarcinoma and endometrioid adenocarcinoma. It can really fool you, and you have to be very careful. Endometrioid adenocarcinoma can also show CDX2 positive. Sometimes can show goblet cells, but typically it would not show comedonecrosis like colon cancer. Endometrioid carcinoma will show more squamoid areas. Those are more helpful. But of course, stains are very, this is more easy because this is, you are seeing submucosal growth pattern, right? But this one was hard. And these are the stains. You can always do CK7, CK20, CDX2. This is endometrial carcinoma, which is staining with CDX2, but it's also staining with Paxate. So not one stain is good. This is another one. You can just call it polydifferential carcinoma, but patient had a history. This one was actually a patient had a cervical squamous cell carcinoma. So this is a P16 positive high risk HPV tumor. So this is cervical metastasis and rectal tumor. So anything which is polydifferentiated, you've got to think about it. This was more like submucosal tumor, single cell. What is this? Then of course, long time back patient had a urothelial cancer. So metastases do occur. This is solid sheets of cells. And KX3 patient had a history of prostate cancer. So always look up the history in a case, especially in a polydifferential carcinoma. And this is a case I got recently. There's a gallbladder with a gallbladder lymph node, and it was all gland forming. And I said, oh my God, metastatic adenocarcinoma. And I looked up in the history, and patient had a history of clinically somewhere it said carcinoid tumor. I said, oh my God, this is carcinoid tumor or neuroendocrine tumor forming glands, and was staining with synaptophysin, chromogranin, and Ki67 very low. So sometimes neuroendocrine tumor can look very glandular. So these are the take-home points. You can have unusual morphological features in colon cancers, biopsies. Be very careful. T4, 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 very important. T4 is the most important thing in colon cancers. Try your hard, grossing, deeper sections. And then tumor budding. Unfortunately, we all have to report, especially in malignant polyps. It is also very helpful in stage 2 cancers, T3 and 0 cancers, where the clinicians are looking for high risk factors to give any chemotherapy. Large vessel invasion is also very, very important. And recognize metastatic tumor patterns. I know I'm short of time, but I thought I did not cover one big topic which we really struggle with, which is looking for malignant polyps. We all deal with adenomas every day. In a larger polyp, we have to worry about adenocarcinoma. I think what helps is, and many times there's a lot of pseudo-invasive process. This is, looks like it's kind of deep if you see in this section, but this part is all surrounded by lamina propria. On low power, this stroma looks different. On low power, they look like infiltrative glands to me. And here, this looks like it's abutting, vessels. So that looks like a T1 adenocarcinoma. You can take help of Desmond, but sometimes it's tangentially sectant. It's very hard. So to me, the pattern is very important. I just did the high power. This is a, with surrounding lamina propria, lobulated configuration. That looks like stroma is a little bit different over here, reactive stroma. So, yeah, this is, yeah, here again on high power, just a small focus of invasive carcinoma. There were multiples. Yeah, here you can see a little bit of reactive stroma. Sometimes desmoplastic stroma is also very hard. In fact, on deeper section, this tumor was trying to go around the space over here, and there's more space over here. So this D240 was circling this tumor. So I thought there was a small focus of LVI as well. This is this is Desmond immunostain. We often do that, and you can see muscle. This is a big polyp. This is a muscle on that side of the mucosa. This is a muscle on the other side of the mucosa. That's the top part, and you can see there's no muscle over here, and all the tumor glands are up. But these are just muscle, the thick-walled blood vessels which are in the submucosa. So they're abutting the thick-walled submucosal vessels. So Desmond stains help in diagnosing. And here is digital pathology. You just put your cursor. So here you can see fragmented muscularis mucosae. I see the muscularis mucosae here. I don't see it over here. So this is like less than 1 millimeter of invasion. These days, we have to do depth of invasion in a T1 colon cancer because less than 1 millimeter, very low risk of lymph node metastasis and no colectomy needed. This is tumor buds. This is tumor buds here. I was looking at whether I see tadpole or not. There's no tadpoling at least, and I don't see a ruptured gland over here. So this is not a pseudo bud. This is a true bud, but it's not a high-grade tumor budding. It's a high-grade tumor budding that determines. That could be a ruptured gland, so ignore those areas, ignore heavily inflamed areas. I'm not counting this. Again, we're not supposed to count on keratin stain, just to help you to figure out those single cells. Um, Also helps in diagnosing invasive carcinoma, right? When you have this. Now you can have that in the intramucosal carcinomas. Remember, definition of malignant polyp is tumor invading in submucosa in colon, and it's still there. That's the definition. There's all the things we need to report. Don't forget. For general pathologists who don't do this every day, everything is important over here. The distance from margins, if it's an intact polyp, is also very important here. Recently, I saw a paper, Japanese paper, talking about 500 microns in submucosal dissections. If it is less than 500 microns, it's higher risk. More than 500 microns, less risk. This is another case, difficulties we come to arise every day, like this is invasive or not. But on high power, I saw a lot of there are hemocyanin-laden macrophages, some hemorrhage over here. I don't think it was not true. It was not true desmoplastic stroma. In fact, it was mostly within the mucosa. So I called this as a pseudo-invasion. I did not call it, but it is a prolapse phenomena. And these are all the features supporting prolapse or pseudo-invasion. These are hard cases clinically. These are features written in the textbooks everywhere where you read. Acellular mucin is very common. And sometimes it can be lined by epithelial cells. And in fact, the lined up epithelial cells can sometimes be seen floating in the mucin, which is a criteria for mucinous carcinoma. But then you have to look at everything together. Lobular configuration, surrounding stroma, surrounding lamina propria, these are things helpful. So I thought I should cover this. Um, um, that's another exam. This is an adenocarcinoma, poorly differentiated, still forming glands. Do neuroendocrine carcinomas only when it really looks like neuroendocrine carcinoma to you. Otherwise, you might get confused. This was synaptophysin positive. I don't think, to me it's a classic neuroendocrine carcinoma features over here, but it's poorly differentiated. Difficult case. I think I'll stop right here so we can discuss. And I'm going to put my video on. Let's see how I can do that. Um,
Yeah,
and
you're good.
you
I
can
think,
also do the
yes,
answers. All
yes,
right.
yes, yes. Okay, no, no, thank you so much. Thank you, Dr. Dhall, for this excellent talk on this such a practical topic, which we deal with every day, whether we are doing regular GI pathology or not. But your video is off, Dr. Dhall.
Oh, all right. Hold on.
Yeah. Okay,
Okay.
it's back. It's back. Yeah, no, thank you. And so you would be very happy to know that there were so many colleagues of ours who joined from different parts of the world, and also your residents who joined in good numbers. Thanks to the residents from your program at Baylor Scott and White's for showing up for Dr. Dhall's lecture. So it's a bonus lecture for you guys. And the questions I have, I will read for you, Dr. Dhall. There is one of our colleague from Peru has a question. Let me read it for you. The question is this. Let me see. How can I read it? 1 second. Mm, yeah, I don't know where it is lost. Okay, let me see it again. So this is I will read it for you. So that our colleague had a case who is an 86-year-old patient. So the patient had a colon cancer 20 years ago, and he got an ostomy. And now there is a cancer that is at the ostomy site. So the question is that should it be considered as T4? And there is a continuation of that question is that is this invasion of the ostomy an invasion of another organ? So, and I have not found literature about the invasion of a new colon cancer over a previous ostomy. So please, if you could help me. So I hope you could understand
That's
the question.
that's a very rare scenario. But anyway, we do this won't be, first of all, there are rare tumors described at ostomy site. So 20 years back, I guess it could be a new primary. And I don't know how would I stage that unless maybe you can talk to the clinicians if there's no other site of tumor and only tumor at the ostomy site. Then you could you stage it based like a new primary, and if it involves serosal surface, you call it T4. And I don't think it would be very hard to tell that it is a recurrent tumor after 20 years. Now, some tumors are known to recur after a long time, such as breast carcinoma. I'm not aware of that late recurrence of colon cancer. Um, yeah, I'm sorry, I can't help you much, but you have to look at clinical scenario. But primary tumors at colostomy sites are described.
And just a question, like, I mean, at this point, it's my thought that the staging is probably not important, right? Like, if you are diagnosing cancer at the ostomy site, and that information itself is quite valuable to your treating physician, right? So, and if they have taken a biopsy, I don't know if it was a resection or a biopsy, probably that's a biopsy. So, yeah. Thank you, Dr. Dhall. So
Yeah.
there is another question from our colleague who has joined from Afghanistan. So the question is there any helpful strategy for distinguishing disclosed neoplastic cells with actual neoplastic cells reaching to the serosal surface? So is the continuity of the cells with the main tumor enough? I think it is about T4. Yeah, that's it. That's the
You,
question.
so, sometimes you can see as a buttering thing, tumor cells floating outside. Of course, the tumor has to be pretty close to the serosal surface. And if you're seeing tumor cells on the serosal surface, there has to be some kind of a reaction on the serosa. I think that is one of the criteria of CAP, right? Tumor seen on the serosal surface with serosal or mesothelial reaction. But please make sure it's not the carrot by knife or like an artifactual displacement, which is kind of common too. So you have to see reaction around it to call it T4. What do you think, Rifat?
I agree. And I mean, so maybe like as you have mentioned multiple times, that at least if you're not sure, take a couple of deeper levels and then see like, is it real or not? And then Dr. Dhall has shown so many good pictures that you have to make a judgment call sometimes that whether you want to call it T4A or not, because she showed a picture that in a previous level, the mucin was only at the serosa, but like at the deeper level, the cells were shown up on the serosal surface. So that sometimes you have to take a judgment. You have to also remember, I feel that it's a 5 micron thick section. So whether you do not see a tumor cell at the surface at that level, it may always be there at deeper level. And how many deeper levels you can keep taking. So sometimes I believe you have to take a call depending on the patient situation also. Right, Dr. Dhal?
Yes, yes, I totally agree. Yes.
There is another question from our viewer again from who joined from Afghanistan that for vascular invasion, is it necessary to see actual attachment between neoplastic nest and vascular wall to call it a vascular invasion? So again, he's mentioning that it's a dislodged neoplastic cell problem.
Yeah, recently there are two papers published about vascular intrusion or pseudo-vascular invasion, especially in these colon polyps with the prolapse phenomena. So yes, you can have displaced tumor cells in the vessel. I have to say, I have not seen very commonly in colon cancer. This is more of a problem in the uterus, I think, in GYN. Um, um, I, it's a difficult question you're asking me. I think, okay, if you see a my mentor used to say, if you see just one focus of LVI in a bigger vessel in the entire tumor, it's probably not an LVI, it's something else. If you see LVI, you will see more. If you see more deeper sections, and again, deeper sections are helpful to see the point of attachment, to see some fibrin. And the tumor cells change some morphology when they're in the vessel. They round up a little bit. So, what is your experience, Rifat?
No, like again, like I mean, what do you do when you're deeper level that the tumor cells are lost?
Yeah, I know. I
And
know this. Just
And as
find another
Dr.
focus, I think. Find another focus because when
Yeah,
you see small vessel invasion, you just don't see one. In a resection, you will see more areas.
yeah,
So I think that's the thing. And of course, if
exactly.
you see a big fragment with a blood vessel in it, within a blood vessel, then it is a pseudo invasion.
Mm.
Yeah, but yeah, I agree. This is also a problem. Share with your colleagues, do deeper sections, yeah,
D240.
do. Yeah.
And then, jokes apart, actually, as Dr. Dhall mentioned rightly, that this becomes more of a problem in malignant polyps because that is an poor prognostic factor in a malignant polyp, right? Like as she has mentioned multiple times that it is very important to report the malignant polyps properly because, like, I mean, there your tumor budding is important and vascular invasion is important. And many a times we see the report that suspicious for vascular invasion. Personally, what I feel that as much as possible, we should try to avoid that terminology. It doesn't help the surgeon. If we say suspicious, most of the cases are taken to the tumor board. So, like, I mean, they do not know what to do. So, if we say suspicious, maybe this is the time that we show the cases around to our colleagues and make a confirmed decision on either side. Better do deeper levels, do D240, and take a judgment call whether it is negative or positive. Suspicious, I think, is very unhelpful. What do you think, Dr. Dahl?
I totally agree. I just don't say suspicious. In GYN, I think there was this at some point in synoptic report, there was a word suspicious. But before doing I don't say suspicious. I make a judgment, I do a judgment call. I don't want to confuse the clinician. Even with low grade, high grade dysplasia, I'm never, either I will say high grade dysplasia or I won't mention it because I don't want to leave the clinicians in limbo. It's all, yeah. So just make a decision and do stain. Sometimes, you won't believe it's like I have caught so many small vessel invasion just by doing stains and large vessel invasion just by doing elastic stain. And especially in your practice, if you don't look at colon cancers every day, stains would help you. Yeah.
Thank you. Our colleague has a comment who was asking questions from Afghanistan that in that situation, I think one case will fill a complete day for a pathologist with all those things to find and to report. It seems challenging. I think we agree.
I agree. It's challenging. It's not easy.
Yeah, so there is another question which is little unrelated is do you test all colonic carcinomas for MMR or MSI?
We do. I think in US, most people are doing it on colon cancers and yeah, and we do it on biopsies. Where Rifat, what about in your hospital?
Yeah, same here. We do in all biopsies. There is a all biopsies like disregarding the patient's age and all. And there is one question which keeps coming that do we repeat it on resections or do we repeat it on metastatic sites? I don't think like that is always necessary, right? Because I mean, I haven't received too many requests to repeat it on resections or on metastatic sites. So if there is any definite necessity, maybe we would do it only on request. What is
Yeah.
your
I
opinion,
don't
Dr.
I
Dhall?
don't repeat it on resections only when there are difficult IHCs or when they were not
Right.
done.
Hmm.
Yeah, I always when I'm reporting, I always look in the prior biopsy, and most of the time it's done in biopsy, so I refer to the prior biopsy. No, I'm not repeating it.
Right. And sometimes if there is an ambiguous like testing result, suppose you are getting a report from an outside institution and the patient is getting treated at your place, and then you don't have the slides with you, and then there is some doubt about it, the stains were not good, maybe then you can repeat it at your own institute and get the block. So otherwise, probably not, right?
Actually, another question, yeah, another interesting thing is I used to actually say in my notes that, oh, it was done in the outside lab, and I used to quote that. But one time I happened to do it, and actually it was not interpreted correctly. So you
Right.
have to really know your colleagues or people who have an expertise in reporting that. Especially, when you have like when the tumor cells are, you always compare it with the internal control, right? And if your stain is less than the internal control, all don't just say intact, either say equivocal or do something else, because I think that's a common mistake. People are not comparing with the control and that punctate staining. So
Right.
it has to be a perfect staining to call it intact, otherwise leave it as equivocal, so at least it can be repeated on resection specimen.
Right, that's a good question. And nowadays, I think, I mean, to do MSI in many places is not very difficult. Like if you have equivocal staining, it is important to, I think, like mention it that it is equivocal rather than calling it intact. I mean, if your institute has researchers, they can do MSI. And if you are doubtful and this is not from your lab, because if it was done in your lab, then you know the standard. But if it was from outside and you are not sure about the stain, please repeat at least the MMR in your own lab. And because otherwise, like, because if it is actually those punctate patterns, as Dr. Dhall mentioned, maybe they are actually, they are lost and they are microsatellite unstable. And then that is helping the patient to get that, treatment with
Chemotherapy.
checkpoint inhibitors and all. I think that's very important, right?
Yes.
Um, there is another question from another a viewer from on Facebook that from Romania. So at this time in Romania, just local advanced cases and metastatic cases are tested for MMR, which is free for patient. Oh, that's interesting.
Yeah, I mean, in a way, I think, okay, for advanced tumors, of course, we are doing MMR for the treatment purposes and prognostic and predictive purposes, right?
Mhm.
For for early cancers, we are doing it for the possibility of Lynch syndrome, right? So where there are less resources and where the people need to be cost effective, I think it is okay if you're doing MMR on all the cases where you see there's a potential of Lynch syndrome. But I think there are studies that you will miss few cases, some percentage, a low percentage of Lynch cases if you don't do MMR on all colon resections.
Right. No, again, I think these were the questions from our viewers on Facebook and YouTube. But like, there are some points that I wanted to share with you and have your opinion. Is that you mentioned something very important in the very beginning about the neuroendocrine markers positivity in colon cancer. So, which has always created debate at many places, including at our institute also. Like, I mean, whenever you have synaptophysin positive, so do you want to start calling it mixed neuroendocrine or non-neuroendocrine tumor? And you showed good examples that when synaptophysin is positive, so I mean, and it is known, you have shown that paper from Dr. Shia that synaptophysin can be positive. We don't have to call it mixed tumor. And but you mentioned about that this often happens in patients who are treated. So have you seen examples of the synaptophysin positivity or literature? I'm not sure that even in non-treated cases, you see like synaptophysin positivity and
Oh yeah,
right, right?
yeah. I don't know how many times when people do neuroendocrine markers when there's just a polydifferentiate adenocarcinoma. Um, and then you're stuck if it's so this case I was showing you an example which synaptochromogram was negative, which is more specific marker. But I think you can fall into a problem if you stain with synaptophysin with any polydifferentiate tumor, because any polyadenocarcinoma. So if you're seeing some gland formation in the tumor or here and there intracytoplasmic mucin, I don't do synaptophysin chromogram. You should only do it when it looks like, wow, that's a neuroendocrine carcinoma. So morphologically, it really has to look like neuroendocrine carcinoma to do neuroendocrine carcinoma markers. I know saying is easy, it is difficult, and it will remain a difficult topic. There, in fact, there were some papers about how about adenocarcinoma with new. Let's say we are staining polydiff adenocarcinoma, and it's staining with neuroendocrine markers. Does it have any prognostic significance? I think there are mixed results. As some paper says they behave bad, but mostly people say no. This is all. You should not do it. It is not important. Um, so yeah, so I think markers should only do it when you think it's like a small cell carcinoma or the case I showed you, sheets of markedly very uniform cells. So to me, the key part is nested sheets and uniform cells, even though it's large cell or small cell. But I know you can get into a very tricky cases and you do the best what you can.
And I think thank you, Dr. Dhall, for explaining it because the main problem is the moment we use the word neuroendocrine, it has a big impact on the patient's management. The type of chemo also changes because we have used the word chemo neuroendocrine carcinoma, which might be we are not doing a service to the patient rather than doing a disservice because we call it neuroendocrine when it is not. And then the therapy has changed, right? So what do you think, Dr. Dhall?
No, I agree. I think we should never top line it.
Yeah,
Only when on morphologically it looks like neuroendocrine carcinoma to you, then you do stains. But if let's say you are dealing with an undifferentiated carcinoma, which are described in everywhere, right? And then in any of, if let's say so undifferentiated, then of course people try neuroendocrine markers. And in that case, if you see sufficient neuroendocrine markers positivity, then you can say this could be neuroendocrine carcinoma. But I'm talking about rare circumstances
right.
where even I have struggled with should I call it, should I not? But then in the comment, talking to the clinician and things like that. But in general practice, stay away from it unless you think it looks like the two cases I showed you, you see a distinct component, a separate component, not just moderately differentiated adenocarcinoma merging into polydifferentiated adenocarcinoma. I do get questions, should I do neuroendocrine markers? I said,
Right.
no, I still think it's adenocarcinoma, don't do it. You will get into a problem. Yeah.
And if I believe that if one is very worried, at least add two more stains, right? Not just synaptome, which is the most sensitive. At least add chromogranin, and if you have the resources, add the third one, INSM1, because they are
Yes.
more specific. And if you have discrepancy, then you know that, okay, like, I mean, this is an overcall, right?
Yeah.
I think that's all the questions I found, Dr. Dhall, on our different online platforms. And you would be happy to hear that because we had so many viewers today who joined because this is a very practical problem for all of us, whether we are doing pure GI or general practice or anything. We had viewers who joined from Bolivia, Peru, South Korea, Egypt, Italy, Mexico, Tanzania, Slovakia, Assam in India, Afghanistan, Romania, and they are all thanking you for discussing this very relevant topic and then sharing your insights on how to solve these issues. And there is so much more that can be discussed. And like as you say, that malignant polyps itself is a different topic on its own to discuss. So hopefully we will be able to invite you at another time so that you can discuss on malignant polyps or some other relevant topics whenever it comes like that. So and again, like thank you so much, Dr. Dhall, for our viewers. If you like these lectures and if you like podcast lectures, so please follow us on social media platforms. And then we have on Facebook, YouTube, Instagram, as well as X, so you can stay updated. So there are a lot of good sessions coming up. We will keep announcing them. And our next lecture is actually on AI, and we have a series going on digital pathology and AI. And we will be joined by Dr. Human Rashidi. He is a very prominent digital pathology or AI expert, and he will be talking on generative AI. So this is a topic that actually we cannot ignore. Like, I mean, it's going to be the reality coming fast. So it's good that we all get educated about it sooner the better. So join us on July 29th, same time with Dr. Rashidi and same time. And thank you again, Dr. Dhall, and thank you all for joining us.
Thank you. Thank you, Rifat, for doing this. Okay.
Thank you so